So before moving to UK, he studied at NIMHANS Bangalore, and he worked as a consultant neurosurgeon at JNMC Hospital in Belgaum, Karnataka for a few years. Then he did his FRCS and became a consultant at Southampton way back in 2010. Since 2010, he is there, and his main interest is on functional neurosurgery, especially spinal cord stimulations, deep brain stimulation, and neuropathic pain. And with this small introduction, I request Dr. Girish to welcome to this program and take over and start presentation. Welcome, Dr. Girish.
Thank you very much, Satish, for the kind introduction. It's really a privilege to be talking again to you guys. I really enjoy. This is the photo I've just pulled up from the man's. There you are, Satish, with all big smiles there, as well as Swaroop, but not, as you couldn't see NC in that. So this is where I work. This is quite a big hospital, university teaching hospital. It's quite a sprawling medical campus. And I'm just trying to find out this. Just going to go there. It's quite a vibrant and multicultural city. And we have a huge catchment population to cater to, especially in neurosurgery. So it's quite a busy teaching hospital. So today I'm really going to talk about the recent advances in neuromodulation, and there has been quite exciting changes that has happened in the last few years. So I'm kind of really going to skim through all these advances. So for a successful spinal cord stimulation team, you need really a team. It is a multidisciplinary approach. So this is my team. With the various pain consultants, pain nurses, your psychologist, the reps, etc. So you need a good team to start doing the spinal cord stimulation. Also, I mean, in this we have various research nurses who help us with various research trials. So today, really, I'll be talking on various aspects which I've highlighted here. And we'll go through each of these points one by one. Failed back surgery syndrome, this is a term that has been used for several years for patients who have had successful spine operations but are left with severe back and leg pain. And I have to say, it is a term which no spinal neurosurgeon or spinal orthopedic surgeon would like, because the moment we write FBSs, they think that, this surgeon is a useless guy and he has failed in his operation and what have you. And of course, there are other points that I've highlighted here. So the FBSs really is not a term that addresses what we deal. There's much more to it than just simple failed surgery. So there was a need for a better terminology all along. Fortunate, as you can see,
Dr. Girish, just a minute.
Mm-hmm.
Can you? There are a lot of people are entering. I will stop sharing for a minute. I will take over as this thing, and it will be easier for you. Stop sharing.
Okay. I'll stop sharing. Okay. Okay.
1 second. Yeah. Go ahead.
So should I start sharing again, yeah?
Yeah.
Okay. Are we there back on? Yeah?
Yep.
Okay. So as I was saying, there was definitely need for a better terminology. I'll just see why it's not moving. Okay, and as you can see from this graph that the number of publications here, which mentions FBSS, has really increased exponentially. So a group of researchers have come up with this new term called persistent spinal pain syndrome. So this is the term that we now use it for failed back surgery syndrome. Can you hear me? Is it okay? Yeah. Satish, can you hear me? Or
I can hear you, Girish.
I can hear me. Okay. Okay. So this is the term that has been proposed, and hopefully it will be integrated into the ICD-11. So we divide persistent spinal pain syndrome into two types. Type 1 is patients who have not had any spinal operation, whereas type 2 is those patients who have had spinal operations. So typically type 1 is what is called as non-surgical low back pain, or we used to call as a virgin back in the past, but now it's PSPS type 1. Whereas all other categories who had spine operations in the past, they go to type 2 PSPS. So just to keep you updated. So high frequency spinal cord stimulation has been quite exciting for the last 5 to 6 years now. This has really changed the landscape of neuromodulation, because till the advent of high frequency, we never had a treatment that could address low back pain component of the failed back surgery syndrome. Whereas we could treat the leg pain with conventional stimulators, but we never had a treatment that could address low back pain. And it has always been a holy grail in the field of neuromodulation to address low back pain. So with the advent of high frequency stimulation, things changed dramatically. And that also allowed us to do a randomized controlled trial. I mean, this was the first randomized controlled trial way back in 2005, which was comparing conventional stimulator with conventional medical management. And that showed that the spinal cord stimulation is far superior to medical management in patients with neuropathic pain. And that allowed NICE in UK to commission the spinal cord stimulators on the NHS. But then this was a landmark paper published in 2015, which compared high-frequency stimulation with traditional low-frequency stimulation in patients with back and leg pain. And it really showed that it was far, far superior to conventional stimulation for back pain as well as leg pain. We now have the trial as well as the 24-month data, which was published in Neurosurgery Journal, which showed that the improvement is maintained over 24 months. This shows the responder rate of the high-frequency stimulator compared to all different forms of traditional stimulator. And as you can see, that the blue line is far superior to the black line, which suggests that high frequency is the way to go for patients with back and leg pain. And this is backed by the real-world data, which we now have so many patients who have had high-frequency stimulation, and even the real-world data outcomes, it does mirror the randomized control trial data. So we now started doing high-frequency stimulation, not just in back and leg pain, but we have expanded the indication to various regions, as mentioned here. So we started off with neck pain. There has been an RCT in the neck pain with so-called failed neck surgery syndrome category. We've done it in upper limb, chronic back pain, chronic pelvic pain, and patients who have not had any spinal operations, as well as post-surgical pains and abdominal pain, etc. We still don't know the mechanism of action of high-frequency stimulation, but it is thought to be as kind of direct neural inhibition, which targets the dorsal horns rather than dorsal column, as with traditional spinal cord stimulation, which targets the dorsal column and not the dorsal horn. But the high frequency stimulation also has built-in low frequency paradigms. So you can really combine the high frequency as well as low frequency in a particular patient, expanding various opportunities. So you can use, as I said, you can use traditional spinal cord stimulator using the high frequency battery. You can use a high frequency system, and you can combine the high frequency with low frequency in a particular patient. So for all these patients, you really need to have a patient who has neuropathic pain and not mechanical pain. If a patient has a mechanical low back pain, they are not candidates for spinal cord stimulation. So you need to have typical neuropathic pain, and we use various neuropathic pain scores, common being the pain detect score. And if that's positive, then we go for spinal cord stimulation. Opioid reduction is a big thing in Western countries because there's so many patients who are addicted to opioids. Any patient with non-malignant pain, they are on high doses of opioids, and we have seen that spinal cord stimulator doesn't work if your total morphine equivalent dose of opioids is about 120 milligrams. So spinal cord stimulation allows you to taper these opioids significantly in the post-operative period. But even in pre-operative period, you have to ensure that the total level of morphine is below 120 milligrams. So again, this was confirmed on the various studies that you could definitely start reducing opioids following spinal cord stimulation, which was hitherto difficult. This is a randomized study that was done in patients with chronic neck pain as well as arm pain, and it has really shown that spinal cord stimulation works not only on the neuropathic arm pain, but also had a big impact on the axial neck pain, which hitherto we couldn't treat at all. So it not only addresses the traditional low back pain following a failed back surgery syndrome, but also addresses the axial neck pain following the failed neck surgery syndrome. So I'll just skip that. Non-surgical low back pain, or PSPS type 1, as we now call it, there are a huge cohort of patients, especially in UK as well as US, who have chronic low back pain but have not undergone any operations because they don't have any surgical targets. All they would have is sort of a small disc prolapse or facial hypertrophy or minor degenerative changes, not enough to merit a surgical intervention. So how do we then treat these patients? That's where high-frequency stimulation has been tried in these patients, and it really found to be effective in both a randomized control setting as well as a prospective open-label study. Again, that allowed not only a reduction of pain, but also, as I said, opioid reduction. So there's now a European randomized control trial study of which we are part of as well, which we are seeing how good it is, because this will have a huge impact because the floodgates are going to open if we now start treating all these virgin back patients with spinal cord stimulation. The other important thing is NICE in UK is no longer would commission spinal fusion for back pain because of the lack of strong evidence there. So these are the patients who would now heading towards spinal cord stimulation. I'll just skip through that. This was recently published in JAMA, high-frequency stimulation in patients with painful diabetic neuropathy. And the results were quite astounding, actually. Significant reduction in leg pain, as well as most disability index and other quality of life indicators, indicating that high-frequency stimulation would be a good idea to do in painful diabetic neuropathy. It's in this condition that you don't want a conventional stimulator because high-frequency stimulation is a silent stimulation. The patients won't feel any pins and needles compared to conventional stimulation, which patients will feel a nice buzzing sensation in the area of pain. As it is, these patients will have tingling and pins and needles, so you don't want to burden that. That's where high frequency is much better in this condition. So as you can see that high frequency has got robust scientific data with various randomized studies done in this area to suggest that this is far superior treatment compared to conventional stimulation. And you can see, various ongoing studies that are happening in this field. Okay, then move on to the burst stimulation. Burst was first discovered by Dirk Dierder, who was a neurosurgeon who worked on the natural inherent action potentials that most neuronal systems have, and he thought that burst is the actual inherent way in which a nervous system works. So he then devised this burst stimulation, which is really a burst of action potential separated by a passive recharge back to normal, and then again burst of stimulation. And the reason why burst spinal cord stimulation seems to work is, of course, it is subperception. That means patients won't feel the stimulation. But what has been hypothesized is that burst stimulation also acts on what is called as the effective part of the pain pathway. So you have lateral spinothalamic tract, which is the pain pathway, but you also have the medial pathway, which is the affective component, which ends up in the medial cingulate gyrus. And what they have studied is that when you have patients have burst stimulation, the medial pathways light up as shown in this, and that is said to be much better, because although patients have good pain relief, even if they have pain, they're no longer bothered by it because of the affective component involvement. And it's clearly shown that the burst stimulation in that study is significantly better than tonic stimulation or placebo. What other advancement that has occurred in this area is use of what is called as pulse dosing. So you don't really need a burst to be on for continuously. You don't need this stimulator to be on continuously. You can leave the stimulator on for 30 seconds, leave it off for 5 minutes, or different sort of paradigms are there in this area. And they've shown that a low-dose spinal cord stimulator is better than a stimulator that is on continuously. And that also allows you to use a non-rechargeable battery, as well as you can conserve the battery life because you're really using very low dose spinal cord stimulation. So in a study which is called as BOLD study, they really showed that using pulse dosing is better than continuously on spinal cord stimulation. And you can use different paradigms. You can go down to almost like 1.8 hours on and rest of the day off. In some, you have 4 hours on and 20 hours off, or 6 hours and less than that. So, and they've really shown that it does work that way. So we now, all patients who need burst spinal cord stimulation, we straight away go for microdosing or the pulse dosing paradigm. So the StemWave is a new type of device that we now have. It's a wireless system, i.e. there's no battery implanted. The electrode itself has a clever chip built into that. And once you implant it, using a wearable antenna, which they have to wear it on a Velcro or on a belt, it communicates with the chip inside. And that stimulates the spinal cord. So could use both high frequency and low frequency in this, but there has been some technical problems with the device. So currently the company is working on that. But it's a good system if you're using it for peripheral nerve stimulation. You don't need any implantable battery. I've done loads of spinal cord stimulator with it, but of late, as I said, there is some technical problems with the copper wire that you have to insert through that, and that's where we're having a problem. But they're working on it. So we use this in patients who are so slim that we can't implant a battery, or patients who are undergoing cancer treatment and you still need some spinal cord stimulation. These are the areas where you could consider a StemWave SCS. Boston Scientific has come up with a new type of device called, or a concept called Multiple Independent Control System, MICC. All other devices, the battery powers all the electrode contacts simultaneously, whereas with the Boston Scientific system, each of the electrode contact has got a separate power source. So that really allows you to use the stimulator in a different way, using combination therapy, using various sub-perception algorithms, or you can even do what is called as waveform automotion. With their existing software called contour algorithm, you can really have combination of various waveforms that you can use to get adequate pain control. What I might take is that, there's no particular frequency or waveform that is suitable for all patients. You'll always have patients who have failed high frequency system. You'll have patients who have failed the conventional frequency system. So the battery, you need to have the ability to use different waveforms, and that's where this MICC concept is really important. It works both in spinal cord stimulator as well as deep brain stimulation. The next advancement is the concept of closed loop stimulation. Now, traditionally, when we say closed loop, ideally what you want is basically to capture a marker for pain and then give a stimulation to treat that. But closed loop stimulation is not in that sense here. What this is doing is it's trying to capture an indirect marker of pain relief by knowing how much of dorsal column we are stimulating, using what is called as evoked compound action potential. So that this electrode can both stimulate as well as receive the neurophysiological studies. So you really capture the evoked compound action potential and then see whether the stimulation is adequate or not, and then you adjust your stimulation. And they've shown that if the ECAPs are maintained throughout 24 hours, patients get much better pain relief, because what you can see in this diagram on the left side, that the stimulation may not be in the preferred range. On the right side, you can see that in the manual SCS or the traditional SCS, they can either have overstimulation or understimulation, depending on the position of the body or valsalva maneuvers, cough, etc., which is shown nicely in this diagram here. So on the left side is a fixed output or the traditional stimulation. And you can see that the evoked compound action potentials fluctuate so much, but the stimulation is not able to adjust there. Whereas with the closed loop system, with all the changes in the ECAP, there's a change in the spinal cord stimulation amplitudes as well, so as to maintain the ECAPs constantly. So this is the concept of closed loop stimulation, and the initial publication, the Avalon study, as well as the EVOKE study, which has recently been published, they definitely have shown that the 12-month and 24-month data appears to be far superior to conventional spinal cord stimulation, with improvement in various components such as the disability index, the sleep index, and the pain scores, of course. Nalu came up with a different type of system. Again, this is a wireless system with a very small chip that you have to implant. as you can see in that the slide here. So this is the actual chip that goes in, which is then connected to the electrodes. And the patients have to wear this disc, which is the size of a small coin. They have to place that disc over where you have implanted the chip here, and using an app on the iPhone, you're able to then control the device. So again, this could be very useful in patients who have low body mass index. And what NALU, in fact, NALU means a wave actually. So what they have used is a layered or patterned waveform, and they think that has potential to stimulate various targets for better pain control. In fact, even before the company was launched, we were part of this study where we studied these waveforms and sort of decided how good was the outcome based on those waveforms, and it was certainly good. So this has just been released in US. It's not come to UK yet, but this is something you can use it in patients who have low body mass index or patients who don't want to have a implantable battery. If they don't want that, this is a good system. Medtronic has recently come up with a completely different concept, and that seems to be getting more and more popular. Hitherto, we were treating spinal cord stimulation and we assumed that we are stimulating just the neurons, either the dorsal column or the dorsal horn. But Stimgenic was a company that tried a different type of waveforms that could stimulate the glial cells within the spinal cord, because glial cells do play a key role in transmission of pain signals. And then, of course, you have more glial cells than the neurons within the spinal cord in the ratio of 12:1. So if you can have a system that can both stimulate the spinal cord as well as these glial cells by using different types of waveforms simultaneously, can you improve the outcome? And this is what has come out of that research study. It's called DTM system, or the differential target multiplexed, and they found that the back pain responder rate was very good in this category, as well as the compared to the conventional system. So there are so many different types of waveforms that are coming out, each trying to outsmart the conventional spinal cord stimulator or even high frequency spinal cord stimulators. So there's quite exciting developments happening here. As you can see, they found that the pain relief, the back pain responder rate was very good in this category, compared to as well as the compared to the conventional system. So there are so many different types of waveforms that are coming out, each trying to what's called as outsmart the conventional spinal cord stimulator or even high frequency spinal cord stimulators. Most of the spinal cord stimulators, there's quite exciting developments happening here. As you can see, they found that pain relief, the back pain responder rate was very spaced apart. You don't have many electrodes to capture and read the data there. So they have come up with this high density 64 contact electrode, which has ability to both capture and data, as well as stimulate the spinal cord, and they think this is much better for targeting pain control, and also this is going to be used in patients who have traumatic spinal cord injuries to improve the motor function as well. But we need to watch the space here. I'll then go on to the dorsal root ganglion spinal cord stimulation, which has been there for a good 5 to 6 years now, and it really works well in patients who have focal neuropathic pain, because you don't really want to stimulate the entire spinal cord if the patient has pain in a very small area of the body. So this as just a brief.
Girish, there are some questions. You want to take the spinal cord stimulation questions first before they go into DRG?
Okay, yeah, certainly.
Okay. The question is, what are the ideal cases for the spinal cord stimulation? And if you have a case, you can demonstrate that. That's number one. Number two is, there's a question to say that, how many levels above the pain level you usually stimulate? Question number two.
Okay, yeah, good question. So the ideal patient, there's no ideal patient anywhere. But yeah, so what you need to do is really a multidisciplinary assessment. So patients would have had chronic neuropathic pain for at least 6 months. Their pain score should be minimum 5 out of 10. They should not have any surgical targets. There's no usual medical comorbidities. And there should not be any psychological yellow flags. So all these patients, majority of these patients get seen by my pain psychologist to make sure that there are no psychological flags. So a typical patient, for example, patient has undergone 1 or 2 or 3 spinal operations. They're still left with severe back and leg pain. You've tried all conservative pain medication. Nothing is working there. They're psychologically good. They're despite pain, they understand what is called as pain management strategies. They're not fighting their pain. They're pacing their activities well. So they know how to manage their pain. So we always say that spinal cord stimulation is not a cure. It's only an adjunct to your standard pain management strategies. So these are the kind of sort of ideal patients. It doesn't have to be failed back surgery. It can be pain anywhere as long as they have gone through the conservative management. Regarding the level, so with the conventional stimulation, we always used to do, we still do on-table testing to see where exactly is the stimulation-induced paresthesia. Is it overlapping we need that to overlap the pain area. Okay, so generally most patients with failed back surgery, you're looking at somewhere between T8 to T11, plus or minus above or below, depending on how you map intraoperatively. Whereas with high frequency stimulation, it's purely anatomical placement. Okay, so most failed back surgery syndrome, your sweet spot is what is called as T9, T10 disc space. So as long as you have 2 electrodes placed straddling this T9, T10 disc space, that's all you need. You don't need to do any on-table testing. Just place those electrodes in the epidural space from T8 to T11, but really concentrating around T9, T10 disc space. Again, of course, if it's neck, you need to go in the cervical region. But you're right, it needs to be above your pain area.
How many levels above the pain area?
Well, I mean, generally, there's no fixed this one. If you're conventional, you're doing mapping, whereas generally, I would say 2 or 3 levels above. Okay. Of course, for all the lumbar problems, you need to go really in the thoracic spine. It's basically you need to capture those fibers which are subserving that pain area. That is the whole idea.
See, many of the viewers here are the fellows and the residents. There's a question to say, what are the classical symptoms you take it to say it's a neuropathic pain?
Well, if it's a burning pain, or if it's an electrical shock-like pain which is constantly present, doesn't go away. There are good days and bad days. There will be what is called as allodynia, touch allodynia. So if you touch the area of pain, normally it shouldn't be painful, but these patients have severe allodynia, which means you can't touch that area at all. And they say that even when they're sleeping, they won't allow any bed sheets or anything to touch that area. So allodynia is a very classical sign of neuropathic pain. So a constant burning electrical shock-like pain with sharp exacerbations, pain which is present constantly, might disturb their sleep. There's a touch-induced allodynia. All these are classical features of neuropathic pain.
What about post-radiotherapy, Girish? Do you think it works well with post-radiotherapy pain?
Depending on where is the radiotherapy. I mean, if it's to peripheral area and if there's a nerve damage, definitely it works. One area where spinal cord stimulation does not work is if it's a central neuropathic pain. So if there's a say, signal change in the spinal cord itself, and be it from multiple sclerosis or transverse myelitis or cervical disc prolapse with signal change in the cord, that unfortunately, that's where it doesn't work. Same with spinal cord injury with signal change in the cord. With radiotherapy, if it's a peripheral damage, yes, it should work.
Yeah, and I was about to ask that question because there is one question from Jaiswal to say that does this work for patients who had a cord injury and paraplegic?
No, it doesn't work, unfortunately. It doesn't work.
Okay. And there's another question to say, how do you monitor the patient and what exactly patient feels and when they start feeling that it's getting better?
Well, I mean, with the spinal cord stimulation, we always do a trial initially to see if it works or not. Okay, so that trial period is about 1 to 2 weeks time. So you place electrodes in the epidural space, connect it to external battery, do the stimulation. They go home. They start noticing the difference within 24 to 48 hours. There's what is called as washing in period, and then they maintain a pain diary during the time of trial. And they within a week they'll come to know whether this is working well for them or not. If it doesn't work, we always extend the trial for another week by changing different programs. So 24 to 48 hours they'll know whether it's started kicking in or not, and then only if it works you then go for the full implant.
Okay, and considering the cost of this, there's a question to say that what is the life of the stimulator? And what are the reasons for revision surgery in your experience? So when did you do the revision surgery? Within how many days?
So the rechargeable battery lasts between 5 to 7 years. So they would need replacing that battery 5 to 7 years. With the Bold XR, with the microdosing, of course, the battery life has now gone to 10 years. But with the high frequency and other systems, you also have rechargeable battery, which lasts 25 years. You have to charge frequently. With the high frequency, because it takes a lot of energy, you have to charge it every day. Whereas with the other conventional systems, you have batteries which you need to charge once in 1 or 2 weeks' time. With the revision surgery, if the leads migrate, then you may have to do the revision, or if the patient wants a paddle implant after lead migration, then I go back and put in a paddle. But otherwise, the indication for revision would be either lead fracture, which is rare, or lead migration, and of course, if there's infection.
Infection, okay. And what is the satisfaction rate from the patients?
About 70 to 80%. It makes a huge difference to the quality of their life. Most patients, they start tapering their pain medication in the first 6 months after the operation. They go back to work. It completely changes the quality of their life, and that's why the government did the cost-effective analysis, and that's how, despite the massive cost, it is funded free on the NHS.
Okay. And there's a question, if you have 2 demonstrative cases where it made enormous difference, if you show those cases and if there is a small video, they appreciate it.
Okay, let me just see. I'll just stop sharing this. And,
no problem. Yeah.
Okay, can you see these slides now?
We can see. Go ahead.
Yeah, I'll just go to the slide that I wanted. Okay, so these are some example cases that we did. So this was treating a phantom limb pain. So this was a 29-year-old chap who had post-traumatic amputation of right arm following a motorbike accident. He then developed severe phantom limb pain of his right arm and hand, and classical neuropathic elements to his pain. He tried various pain medication, nothing would work, and his pain was 10 out of 10 on the numerical rating scale. So I trialed a single percutaneous lead and did an external trial for 9 days. That was in 2015. And as you can see, it was the electrode spanning C5 to T1. And he reported almost 70% pain reduction during the trial. And his pain score came down from 10 to 3 out of 10. So then implanted a paddle electrode for him. I mean, these days, 70% of my work is percutaneous, but a patient young like him, I thought it's better to go for the paddle electrode, which has to be surgically implanted, unlike percutaneous electrodes, which are just minimally invasive. But yeah, it's been 5 years now, and he still continues to have severe significant reduction in his pain as well as improved quality of his life. With improvement in the anxiety score, depression scores, the EQ-5D and the EQ-VAS scores. His life is so better that he's now, doing paragliding. He is managing to get a driving license for lorry, despite you can have disabled driving. Significant reduction in pain intake. So overall, make a positive impact to their life. So this is one example. So this is for upper limb pain. The problem with the upper limb was always, with the conventional, is always difficult to obtain the paresthesia in the correct place. And also with the neck movements, the paresthesia is changed as well with the conventional stimulation. That's why high frequency is much better for neck and arm pain. So this is a 69-year-old chap who had long-standing neck degenerative changes. He underwent anterior cervical discectomy at C5, 6, C6, 7, but that didn't make any difference to his neck and arm pain. As you can see, that his neck was almost 8 out of 10, and the arm pain was pretty high as well. So we did a spinal cord stimulator trial with the electrodes from C3 to C5, and he obtained 80% pain reduction during the trial. And then we again implanted a paddle electrode, and it's been sort of more than 4 years now, and he continues to have significant reduction in his neck pain as well as arm pain. With the failed neck surgery syndrome, I always say, I'll show you this slide. So the Senza upper limb study was done in one of the exclusion point was if the patient has undergone posterior neck operations, because you can't insert the electrode percutaneously in those situations. And that's where if you have if you have a neurosurgeon implanting, then it's much better. So patients who have undergone anterior neck operation, you consider percutaneous implant because their posterior epidural space is free. Whereas if they've undergone posterior neck operation, you can always do an open trial with a paddle implant. So neck and arm pain, it works really well. This is a patient again with failed back surgery syndrome, but also has had a degenerative scoliosis. As you can see, the patient had undergone L4 to S1 hybrid fixation with dynesis. It was then removed. Anyway, the patient was having severe back and leg pain. But in the presence of degenerative scoliosis, it becomes technically difficult because you don't know whether the midline of the spinal cord, does it correspond to the midline of the vertebral column or the spinal column or the spinal canal. So that's the problem there. So as you can see that I've placed the electrode following the curve of the spine, because that's the beauty of these electrodes. You can steer the electrodes. So I did a percutaneous trial with T8 to T11, managed to get 75% pain reduction with good improvement in functional components and sleep. And I then implanted a paddle electrode in that patient, only because she was only 50. And there's a 5% risk of lead migration with the percutaneous system. So we asked them to kind of restrict their movements to some extent, especially first 4 to 6 months while the wires are getting scarred into the epidural space. But any young patient, if they want to remain physically active, I do a trial with the percutaneous system, remove the wire, and then implant the paddle electrode connected to the battery. That I've done for all the coccygeal patients, coccygeal neuropathic pain following trauma. It works well there as well. I won't go into the detail there, but basically for coccygeal pain, and it's not uncommon in this part of the world to have several patients with coccygeal neuropathic pain. I still haven't figured out what is the right target for that. Is it the T9, T10 disc space, which is the classical point for any patients with back and leg pain? Or do I go and target the conus medullaris and chordae equina region for a better control of coccygeal pain? And I've had a mixed kind of picture. As you can see, this patient had T12L1 kind of capturing the conus chordae region, with again, it's been more than 5 years, 6 years now, it's having good pain relief. Whereas in some patients, then go for the T9, T10 disc space. So now classically for coccygeal pain, I don't put 2 electrodes side by side, but one in series. So the top electrode is to cover T9, T10 disc space, and the lower one goes down to L1, L2 to capture the conus and the chordae region.
Yeah, there's one more question. Is there's post myelopathy surgery, tingling numbness and the paresthesia in the hands and legs, and is it going to work?
No, unfortunately, if they have signal change, it doesn't work because that becomes a central neuropathic pain. So if they have myelomalacia, those sort of places, it won't work. But what I do is, if the post-op MR scan shows that the signal change has disappeared completely, I might give a go. But always tell them that it may not work. Certainly, it won't work for the pins and needles and paresthesias. It will work only for pain. But I would be skeptical if they've had any signal changes.
And does this work for the brachial plexus, post-brachial plexus pain?
Yeah, so absolutely, good question. So brachial plexus avulsion injuries are kind of it's pretty nasty pain, of course. So you always want to try spinal cord stimulation before we do DRES lesioning. So it's a mixed pictures. In some patients, it works because there's a root avulsion. It probably may not work in all the cases. But it's always prudent to try spinal cord stimulation, and if it doesn't work, I always offer them cervical DRES lesioning. But yes, it does work.
And with your experience, how many patients with brachial plexus neuralgia, injury-related neuralgia, you had a DRES versus stimulation?
Well, all patients, I will first try spinal cord stimulator first, and only if it fails, then I'll go for DRES. I would say it's 50-50, really, 50%.
And how long do you wait before you go to DRES lesion?
Well, I would wait for at least 4 to 6 months, and we try different programs and try to optimize the stimulation. If it doesn't work, probably it's not working.
Okay. Yeah, you can move to the next that address this thing.
Yeah. Do you have how much time do you have?
You have another 15 minutes to go.
Okay. So what? I'll stop sharing this one and then go to the other one. Sorry, technical problems, but we'll be there.
Take your time. Any problem? Can I help you?
No, just like I need to load that presentation to be able to share, isn't it? It needs to be on the desktop.
Huh.
Oh, yeah, got found it, yeah. Okay, should be there now. Okay, can you see that? Yeah.
Yeah.
Okay. So what I'll because we don't have much time. So what I'll do is I'll just show examples of DRG and then move on to multifidus.
Okay.
So, Okay, so these are the this is how the DRG electrode looks like. So you place the electrode in the spine, but then you come out through the nerve root foramen. So it lies just below the pedicle of that nerve root. So this is a 4-contact DRG electrode lying in across the dorsal root ganglion. This is how you go into the epidural space. As you can see, the needle going from the spine, then it comes out through the nerve root foramen, and then you do on-table testing to make sure that you're not capturing the ventral nerve root, because you need to be on the dorsal part of the nerve root. And this is a place where you really need to know all your dermatomal levels really well in order to know which DRG to target. So this is again an example of bilateral DRG at L5 for complex regional pain syndrome of the foot. This patient had left foot crush injury with severe neuropathic pain. So he had a L5 DRG, which works really well. This patient had multiple knee operation and was left with severe neuropathic pain in the left knee. We treat quite a lot of those patients now. So you can target L2, L3, or L4, one of those. This patient needed all three actually to overlap the pain area with the stimulation. So this is a patient who had complex pain following appendicectomy operation. So initially I tried dorsal root ganglion stimulator, which worked but not giving adequate pain relief. So then I added a spinal cord stimulator, conventional as well, with the burst system. So as you can see, this patient has combination of spinal cord stimulator as well as the paddle DRG at 4 levels. And with the combination of these 4, her pain is almost 90% reduced, and is working really well for her. We call this a hybrid system. This is a patient who has thoracotomy and has severe pain at the thoracotomy site scar. Some patients do get pain even at the site where the intercostal chest drain comes out. So those are the ideal cases for DRG if you know which level to target there. So that works really well. The other areas where it works is, of course, the post-inguinal hernia operation, groin pain or testicular pain. It works well. This patient had CRPS involving upper limb, so I did a right C4 dorsal root ganglion stimulator. And there's in a randomized study, it was really shown that the DRG is better than conventional if the pain is very focal. Okay, so I'll briefly sort of go to a new type of device called Reactivate. I mean, I've just spoken some time ago about this. But what happens in patients, and this is not a spinal cord stimulation, but it is a neuromodulation device, and it's also called as restorative neuromodulation. And it does not work for neuropathic pain, but it works for mechanical pain. So what happens if you have mechanical pain? Spinal cord stimulator won't work there, so you really need some sort of device that could control these sort of pain. And what happens is there's an initial injury to the spine, which is quite painful, and that causes reflex multifidus muscle inhibition, and that results in functional joint instability. So all these patients who are not candidates for any spinal fusion or spinal surgery and have mechanical back pain, they would have had some minor insult some time ago, but they are now suffering from intractable mechanical low back pain, which is not responding to conservative management, and the spinal surgeons are saying that they can't do anything. So this is where, and if you do MR scan of these patients, most of these people have varying degrees of multifidus atrophy. You try to rehabilitate them by you giving various back exercises, but nothing really works in these patients. And that's where multifidus stimulator is so important. As you can see in the diagram on the left side, you're putting electrodes over the transverse process to stimulate the medial branch because that's the one which supplies these multifidus. So when you implant the electrodes, you have to demonstrate by doing on-table testing that the multifidus muscle is contracting. You then implant the battery. There's no trial, unlike spinal cord stimulator, because unlike SCS, the treatment with the multifidus takes at least 2 to 6 months for you to see any benefit, because it's over a period of time that you're trying to restore the multifidus muscle. So typically they use it for 20 minutes in the morning and 20 minutes in the evening. And when they use it, when they put the device on using their remote control, they can feel the multifidus contracting on both sides. And it's quite pleasant. It's not painful or anything like that. And they use it religiously for, as long as possible. So over from 2 to 6 months onwards, you start noticing significant improvement in their back pain. And I was initially skeptical about this treatment, but having done 10 on the research as a part of the research studies, I was really amazed to see the difference that I was noticing in their back pain, with significant improvement in the quality of their life. So it really works, and it has now been approved on the NHS just a few months ago. So that's how you have the 2 electrodes placed on either side of L3 transverse process to capture the L2 medial branch, and then you implant the battery straight away, and you can see that when you switch it on, it stimulates the multifidus muscle, and it's backed by robust studies, which was mainly the geotypical patients are patients who have primary mechanical severe low back pain. It should not be neuropathic, and there should be some evidence of multifidus dysfunction either on MRI, or we do what is called as probe instability test to see if they have minor instability in that particular region, and that elicits pain. And they should have had tried all various conservative management, and these are the typical patients that we are now selecting for implanting the multifidus device. And it does make a big difference, I have to say. And this was shown on the Reactivate B study, which was a randomized controlled trial comparing sham versus the actual stimulation, with the outcome at 120 days. And there was definite significant improvement in most aspects of the outcome measures. All these patients who are highly disabled with severe back pain to start with, you then make their pain significantly better, with their disability significantly improved following the device implant. So this is something that we'll be doing on the NHS soon. I won't go into the detail about the studies, but it is a very good system to have. Unfortunately, right now it's not MRI compatible, which is slightly limiting, but they're trying to see how they can make it MRI compatible. The other thing is, if you're using only 20 minutes in the morning, 20 minutes in the evening, do you need a big battery there? Can you do something with the external battery? So there are various things they're looking at, but the last 3-4 years they did Reactivate A study, Reactivate B study, and PMCF study, and everything has shown that it really works. So it got FDA clearance and the clearance from NICE now, and to be used on the NHS. So I think I'll stop there.
Yeah. So, the last 2 questions for you. One is the multifidus stimulation which you are doing, it's done under local anesthesia, right?
It can be done under sedation, but generally I have done all my cases under general anesthesia. It takes half an hour, 45 minutes to do that. It can be done under sedation as well, but GA is better because you have to do on-table stimulation, and then you can feel the multifidus contracting, and then tunnel the wires and put the battery in. But people have done under sedation as well.
Okay. And what are the indication for dress stimulation?
I mean, I don't do a dress stimulation. It's just a lesioning I do.
Lesioning,
So I do microsurgical dress lesioning in typical brachial plexus avulsion injuries. Where I go in, when you do heavy laminectomy, you could see that the ipsilateral nerve roots have all been avulsed. So I then go into the dorsal root entry zone and using a knife and a microbipolar make lesion all along the dorsal root entry zone, including few segments above, few segments below. And that works really well for brachial plexus avulsion injury pain.
And now, how do you monitor on table that the patient is going to get the better benefit with the dress lesions? Do you have any monitoring thing you will do?
Yeah, so we do a couple of we always monitor the SSEPs and MEPs, but also there's a test that you can do whether you're on the dorsal column or lateral column, or you're on the dorsal root entry zone itself. So you have to stimulate these areas, and so I place a recording electrode just above where I'm making dress lesioning, and that will be continuously recording the SSAPs. And then with your stimulating electrode, you can stimulate the dorsal column, then you can go to dress, and then you can go to the lateral column. So there'll be different waves depending on where you're stimulating. And that way you can identify the dress. And also, of course, obviously there won't be any nerve roots because they're all avulsed there. And there'll be generally some hemosiderin staining or yellowish staining there. You know that was where the damage has occurred. Yeah, the key thing is to know the anatomy well, because if you deviate either way, you're going to have problems with ipsilateral paralysis, or problems with the micturition and things like that.
So the last question is, considering being in a developing country, the cost benefit ratio for the patients with overall neuromodulation, what's your suggestion?
I mean, I've been scratching my head for the last few years to see why is it that chronic pain is so prevalent in this part compared to India. Is it that in India we have better social support, better, I don't know, there has to be something, or is it that we were not seeing when we were trainees there? But you see huge number of chronic pain patients here, but you don't see that many in India. Is it underreporting, or so? First thing, we don't know what is the prevalence of chronic pain in Indian population, and second thing, of course, yes, it is expensive device, but there's no reason the industry can't make it a bit of subsidy, and then should be available to wider public. But it's a cost that is the factor, I think.
Anybody else has any questions? I think, Girish, thank you very much for taking the time off from your busy schedule. And definitely this is a newer field. That's why we wanted our fellows and the residents to get exposed to these kind of a thing, because the future is becoming minimally invasive in every aspect, from surgery to pain therapy. And some of these things can be done in this outpatient clinic or under the local anesthesia, as you said. I think in the future, and the pain is the ultimate for every pathology. I think if the pain is taken care, many of the quality of life of these patients significantly improve. So that's the reason we wanted this topic, and I'm sure the listeners got benefit out of this. I'm sure more they get exposed, the more they will have many more questions to come, and we can have a future separate field in the pain therapy itself. Swarup, you have any questions?
Nothing. Just to thank Girish. Pleasure listening to you. Hope we'll have another session soon. Newer advances and craniofacial pains. Hopefully.
No problem. Pleasure. Yeah. Thanks. It's pleasure. I'm quite impressed with all your trainees asking so many questions. So, it was a pleasure talking to you guys.
Yeah.
And
you have any questions?
Swarup.
Girish.
I said, well spotted that I was wearing a Sakra world tie.
I know. It's good. Nice to see you wearing a tie.
Yeah. Thank you, Girish. Thank you very much.
Pleasure.
Thank you.
Bye.
Yeah.